Just 1 minute. This 1 minute will be starting. I gotta
Okay, John.
get it ready on various social media.
التفكير مش منه عندنا من سوريا بنطلع من البحر ويجوا.
Okay, one last link. I'm putting this link onto neurosurgery cocktail live so that we go live when it goes live there. That's such a big group. It's 20,000. And as soon as we're on the cocktail, we're ready to go. Okay, we're on the cocktail.
right.
Okay, let's go. 10, 9, 8, 7, 6, 5, 4, 3. Hold on, so I don't have my screen on. 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett broadcasting for Neurosurgical TV. We are honored to have Ibrahim Sbeih, an old friend. He's been broadcasting for a long time here at Neurosurgical TV and a long time prior to when he started with us. And the link is in the text to see most of the videos that he did with us. And it's an honor to have him with us. And welcome, Dr. Sbeih. It's all yours.
Thank you, John, and hello, everybody. My name is Ibrahim Sbeih. I'm a neurosurgeon from Jordan, and we are transmitting live from the Farah Medical Campus here in Amman. So this is the Farah Medical Campus in Amman, where I'm transmitting from. And this is the black iris, which is symbol of Jordan. Today, we're talking about developmental venous anomaly. We'll take it from the clinical, radiological, operative, and pathological correlation point of view. We look at the vascular lesions of the CNS. Lesions are either tumors or malformation. Tumors like hemangiopericytoma, hemangiobblastoma, etc., or vascular malformations. And vascular malformations are classified from the functional point of view, either with shunt or without a shunt. Those with a shunt are AVMs, fistula, and vein of Galen malformation. And those without a shunt, i.e., there are no capillaries between the arteries and veins, are DVAs, developmental venous anomaly, sinus pericranii, capillary telangiectasia, and cavernomas. These two, DVAs and cavernomas, are the most common. DVAs, something like 40 to 63%, and cavernomas 5 to 13%. So we'll concentrate on the DVA, developmental venous anomaly. It is the most common intracranial vascular malformation. If they look in the autopsy studies, 2.6%. If you look into the MRI studies, 0.5 to 0.7 found on MRI, routine screening, or whatever. The old terminology for the DVAs were venous malformation or venous angiomas. This has been changed by Pierre Laguanis from France in 1986. He's a French interventional radiologist. I think our friends here in the auditorium know him very well. He stated that DVAs are normal variation. They are not malformation, they are normal variation of the cerebral venous system rather than a true malformation. That's Pierre, and that's him. He passed away in 2008, but he established the World Federation of Neuroradiology, Interventional Radiology. And also he established the ABC and WIN for those who know and attend the meetings of the interventional radiologists, and I am one of them. So if you look at the venous system from the very beginning, our venous system starts with the intramedullary veins. They coalesce to form larger tributaries, and either they drain into cortical or superficial venous system, or they go subependymal and they go to deep venous system. That's the normal. So something happened in the later trimester of gestation. Something happens which causes the developmental arrest of these medullary veins, and we don't know what, but the theory is that non-specific insults would happen. those non-specific insults are during intrauterine life, either out of fluid obstruction, which is idiopathic or spontaneous, mechanical obstruction or remote shunting. All these factors will cause the maldevelopment of those medullary veins, occlusion, atresia, ischemia, and that would lead to compensatory pathway. So this is not a malformation, this is variation of the normal venous pattern. So like this, if you look at the arterial side, we're looking at in utero, fetus, arterial side, and venous side. In the venous side, there's some stenosis or thrombosis of the outflow vein or mechanical obstruction. And if you look at the arterial side, that there is increased inflow for whatever reason, that will cause DVA to develop. So like that. Tributaries coalesce into a collecting vein, and this would go to a draining vein that would go into a sinus or whatever, like this. Tributaries, collecting vein, and then draining vein. So multiple small veins draining into a collector vein, which is called the head, and this would go into the draining vein. Again, like this. This is DVA in the cerebellum. So tributaries like this go into the collector vein and then into a draining vein. And this head is called caput medusa, or some people call it umbrella, some people call it palm tree. It's just the same. Caput medusa because of the Greek mythology, this head of the female with lots of snakes around the head. So if you look at the AVM here, the DVA, it looks like the caput medusa. People call it palm tree, which is just the same. It looks like a palm. Also the tributaries, collecting vein and draining vein. Or like this, tributaries, collecting, draining, palm tree. If you look at the development of venous anomalies in newborn brains, they can be demonstrated. So this is science, it is not fiction. Again, DVAs in utero and in fetus. And the same in adults with the prevalence of developmental venous anomalies that increases with age. So you classify them into either superficial DVAs or deep according to where they are draining their venous blood. If you look at the histology, if you take a picture at the DVA, it is just a dilated vein, no capillary, no arterial, no capillary component, just dilated veins with thickened walls, fibrotic with hyaline material, and the wall has absence of plastic lamina, loosely arranged smooth muscle. So just a vein with a lot of architectural changes. They could be in the spinal cord, in the brain, or the brainstem. This is one case of mine and the spine, DVA here. They can be mostly in the frontal area. This is the classification for distribution, mostly in the frontal, followed by the others. It could be in the white matter, it could be in the subcortical, juxtacortical, and they could be variable in size. Looking at the radiology, CT scan would show you this, which most people will miss as normal. This is not normal, this is DVA. And if you look at the MRI, you can see the DVA, the caput medusa, and the draining vein in various parts of the brain. Again, you can see the DVA here. You can see them in the infraventral compartment. Again, CT scan will show you the caput medusa arrangement and the DVA. This is not a normal vein that you see in the normal anatomy, but it is draining normal functioning vein. And if you damage that, you'll damage that particular vein. The SWI is very important to show them very clearly. You can see the collecting vein, or here the umbrella. And angiography will show you that in a very clear manner, of the draining veins into collecting vein, and then the draining vein that is going here to the superficial, to the severe sagittal sinus. Again here, you can see it very clearly. With this DVAs, there are certain parenchymal abnormalities. It is within the drainage territory of DVA. is reported in 65% of cases. So you can see this, and people like this may present to you with epilepsy, for example. So the surrounding matter of the DVA, they show signs of a chronic venous compromise. There is hemosiderin deposits, there is gliosis, hemorrhage, atrophy, cyst formation. These are parenchymal changes of the brain in the territory of the DVA. So please stop to think of DVA as benign. They are not. Parenchymal changes like this are due to DVA. Paper from the States, another paper from Switzerland showing the DVA and the parenchymal changes within the brain. That could present in various forms, epilepsy, choreiform, whatever. So the parenchymal changes, they have significant metabolic abnormalities. They could be isometabolic, they could be hypometabolic, they could be hypermetabolic, but mostly hypometabolic. Paper, very nice paper from States, 2014, looking at the DVA here and look at the increased blood flow here. Venous congestion. Here it is the hypometabolism in the areas that we associated with the DVA. Again, here a paper from Italy, a recent one, 2022, DVA, the capotidosa, and the increased cerebral blood flow. So DVA are not simple structures. DVAs can be isolated lesions, like we have seen. You just do brain MRI and you see them. Just like that. Most of the time, 65% are asymptomatic. That's why they were called benign. But the 35% are symptomatic, and you have to be aware of them. They can become symptomatic by stenosis, by ischemia, by mineralization, or by calcification. So this is a DVA with some stenosis. It will present itself in some way. Those symptoms due to DVAs, 6% are focal deficits, 6% by hemorrhage. So DVAs can bleed. 4% seizures, 1% in function. So look for DVA and carefully in every MRI you do. And don't count on the radiology report. You have to read them yourself. Those symptoms can be headache, could be symptoms of hydrocephalus, ataxia, hemorrhage, or thrombosis. One paper from Italy, 2008, this DVA presenting with ataxia and headache. Another paper from Turkey presenting with ataxia. The sole presentation of this patient is ataxia due to DVA. Again, they can present with hydrocephalus. Would you believe it? The DVA is just blocking the entrance of the aqueduct, causing hydrocephalus. And here it is, hydrocephalus. And this is the DVA sitting on the aqueduct. And this is the endoscopy view. This is anterior, this is posterior, this is DVA blocking the aqueduct, like in here. They can present with Hemi syndrome due to affection of the corona radiata, weakness, etc. So this is one case from Italy, again, recent paper. And they can present with the thrombosis. This is a thrombosed DVA presented with symptoms, and when they anticoagulated, it opened up. They can present, as I said, with thrombosis, like in here. Thrombosis again. You can see DVA, you can see the thrombosed here. They can cause basal ganglion infarct, venous infarct. They can cause ischemic stroke. So these are established papers, not fiction, that DVAs can be symptomatic and they are really not benign. They can present as epilepsy. It is a well-known clinical manifestation of isolated DVAs. So this is DVA, and this is hypometabolism there, and this patient presented with epilepsy. Another paper from Turkey, 2020, frontal, which is epileptogenic, as you know, and the parenchymal changes in the frontal lobe causing epilepsy. Here it is presenting with hemifacial spasm, a large DVA pressing on the facial nerve causing hemifacial spasm. And this is the operative view of that patient, where you can see this large DVA pressing on the facial nerve. They can present with pressure on the trigeminal nerve, left facial numbness. This is the DVA pressing on the area of the trigeminal nerve. They can present with coricoid movements because they are in the basal ganglia. So simple DVA, not associated with anything, can present with all these symptoms. And they can also present with hemorrhage. So DVAs can bleed. And if they bleed, bleeding could be intracerebral, subarachnoid, or intraventricular, as in this case. Paper from USA, 2019, hemorrhage, DVA is here, hemorrhage is here. Alone, solo, nothing associated with it. Another DVA like this presented with hemorrhage. So if you're not careful and you go for angiography to see it, you will miss the cause of this bleeding. Another paper with a patient presenting with hemorrhage like this due to DVA. And another large intraparenchymal hemorrhage due to DVA. Dr. Hazem Habib has a case of DVA presenting with hemorrhage. So Hazem, please come over. Thanks, Professor Sbeih. This is one of the cases of mine that was due to DVA. This lady came with deterioration of level of consciousness and severe headache, and it shows here that there is extensive cerebellar hematoma with some edema, and there is even compression of the cerebellar tonsils. If we look at the CTA, and I'm not sure if Professor Sbeih is suggesting to do angiogram or CTA, but probably we do always CTA. What we see here that her basilar system is okay, maybe a hypoplastic vertebral artery. You can see that there was overfilling of the right transverse sinus, which could be normal, but then you can see two collectors, two caput metosa or caput head, they call it a lot of names, filling the posterior part of the quadrigeminal system and causing like small venoma, what we call venous varix. You can see the two collector veins draining into the straight sinus eventually here. So this is one of the few cases that we encountered as bleeding with DVA. I remember in two cases when I was working at the military hospital, they were proposing to do embolization for them. We did in two cases embolization. We went through the venous system and we occluded them. But just to state my experience, one of the cases they had severe hemorrhage after that. So we don't know if occluding DVA, hemorrhagic DVA is substantial. So this is one of our cases. Another intervention with English. I'd like to hear your views about what to do with a DVA that bleeds. Do you go for any treatment, or do you go for whatever you do for those bleeding DVAs, not associated with anything?
Thank you, Dr. Ibrahim. It's definitely a very interesting pathology from different perspectives. As you clearly mentioned, it's a pathology that we encountered often, but we rarely see symptoms from it. So it's a dilemma by itself every time you recognize this pathology. The facts, we know that this is draining normal parenchyma. That's a fact. The other fact is the vast majority of these are asymptomatic in the term of what we see on a daily basis. So the dilemma with seeing all these reports and the case that Dr. Hazem just presented, that they do somehow present with, rarely with some symptoms. And most evidence suggests if you tackle this either endovascularly or other ways, you end up with higher trouble than just observing them. So classically, the conservative management for these seems most reasonable, considering that the risks are typically of re-hemorrhage, assuming this does hemorrhage, which is by itself is exceedingly rare. So in the end of the day, the bottom line, we would say this is most likely treated conservatively, even in the very rare situation of symptoms. And it's always a dilemma when between causation and association. Quite often we see subarachnoid hemorrhage, we don't see the cause, and that patient will have somewhere a DVA. Can you make this a causative effect? Not necessarily. Sometimes it's much clearer, like the cases Dr. Ibrahim and Dr. Hazem just presented. It's just a big venous vertex that looks to be bled. Still, there is very minimal things you can do about it. Thank you.
So, dilemma of, do you do anything for those bleeding DVAs or do you leave them? Most people agree that you treat them conservatively. If it is thrombosis, you give anticoagulation. If it is any associated, you deal with the associated lesion and leave them because they are draining normal brain. And then this paper from Japan, are they benign or not? And they conclude that some authors consider them not benign and advocate surgical resection in some cases. I'll show you one case with epilepsy. They treated that by taking the DVA and they reported nothing happened to the patient. So they can be solo, they can be associated with something. Associated with so many things, but the commonest one is cavernomas, also AVM, fistula, telangiectasia, aneurysm, MS, and tumors. DVA and cavernomas is well-known association. This paper I published back in 1986. I was a resident then. And that's when I was interested in those cryptic AVMs. Cryptic AVMs was the name given to the cavernomas because we used to do angiogram and you don't see anything. So we call them cryptic because they are hidden. And we published this paper back in 86 about cryptic AVMs of the brainstem and the spinal cord. I was then at the Atkinson Morley Hospital in St. George's Hospital in London. And this is the paper, brainstem hemorrhage and the spinal cavernoma. So coexistence of cavernomas and DVA are the most common. 33% of DVAs are associated with cavernomas. And if you have hemorrhage, when you have those two, hemorrhage is not due to the DVA, it is due to the cavernoma. So you treat the cavernoma. What is the bleeding rate of the DVA alone and when it is associated with cavernoma? Alone, it's small, 0.4 per year, while if it is associated with cavernoma, it is 3% per year. So in 2 years, it is 6% and so on. I looked at this paper by Robert Spessler, the famous vascular neurosurgeon from the States, presenting their 300 cases of cavernomas. Beautiful paper. And the paper by his successor, Michael Lawton, about 277 cases of brainstem cavernomas. And here, by the way, is Spessler. He came to Jordan many times. We are in the same community of the World Academy of Neurosurgery. Here we are on the ship in Oman. And he came and he met with His Majesty King Hussein. And he's here at my place having coffee. And here meeting with His Majesty. So looking at their papers, especially on Michael Lawton, 277 patients, DVA was present in 122 cases. One case of mine, the Bahraini boy, 17-year-old, with this horrendous cavernoma and horrendous DVA. And this is his angiogram showing the DVA. Again, different cases of mine with combination of both. So cavernomas, and this is something, cavernomas are known to emerge with time in the vicinity of DVA. This is really a revolution. A revolution in every sense. Paper by a specialist. He says this: developmental venous anomaly, cavernous malformation, and telangiectasia are spectrum of a single disease. Which means that maybe cavernomas are not congenital after all. Maybe they develop later in life in the area of DVA. So cavernoma can be acquired. This is important for the insurance companies. They say we don't treat cavernomas because it is congenital. I tell them you cannot rule out that those are acquired because of this paper. So the theory is that the DVA is there. It causes elevated pressure, causes microhemorrhages, and it can cause the cavernous malformation to develop. Is this true? Yes. Patient, 23 years of age, and what he has is just the DVA. Followed him up. At the age of 31, he developed cavernoma. Age of 31 is not congenital. It is acquired. So stop thinking of cavernomas are just as congenital. Another paper from South Korea. Again, they say the same. This is the medullary vein. Because of the kinky, because of high pressure, there will be DVA, and in the area of the DVA, they will develop a cavernoma. Another case, DVA, and then a cavernoma develop in the area. Third case, DVA with cavernoma developing in the area. So maybe after all, cavernomas follow the DVA. So you start with DVA, and by age you develop cavernoma. Cavernomas are more likely to develop when a DVA has 3 or more medullary veins. The more tributaries you have, the more likely you will have cavernoma. Cavernomas can develop DVA drainage territory, and the combination increases the incidence of hemorrhage and the increase in the size, because you know cavernomas can actually increase in size. And this is the theory of it. Again, they can cause increased cerebral blood flow, as we mentioned before. So there is a causative role of DVA in the formation of de novo cavernomas, increasing the chances of hemorrhage and the chances of increasing in growth. This is the revolution I'm talking about. And when you have a case of DVA and a cavernoma, don't touch the DVA, just remove the cavernoma. I will demonstrate this in this case. Patient from Iraq, 18-year-old. He had sudden onset of headache, double vision, get ataxia, hearing loss on the right-sided limb weakness, and right cerebellar signs about a month ago before he presented to us. And he had actually some drift here, formation drift on the left side. He had 6-nerve pulse on the right side. There's facial weakness on the right side. You can see it clearly. And his auditory function test showed that he has a decreasing ear on the left, on the right side. And he had, as I said, grade 4 House-Brackman facial weakness. This is his CT showing this medullary pons junction cavernoma. This is his MRI. And you can see here, it is in the area where the trigeminal takes off. But you can see a lot of brain tissue here between the surface. So this is not presenting to the surface. Here, this is a thin area that you may go through. So if you go epitrigeminal, it is difficult. But if you go here through the fourth ventricle, it is less damaging. DVA is very well seen here. This is the coronal and the sagittal, and this is the DVA on the angiogram. So it's established cavernoma or DVA causing hemorrhage, causing major deficits. So I chose to go for surgery. I went through tello-velar approach on the right side, and I chose to go through the brainstem in the supracollicular of the facial nerve. Remind you of the anatomy. This is the nucleus of the facial nerve. It goes around the nucleus of the sixth nerve like this. And this is called facial colliculus. So facial colliculus are fibers of the facial nerve going around the sixth nerve. So if you damage that area, you'll damage both facial and the sixth. So this is stria medullaris, separating the upper part and the lower part of the fourth ventricle. This is the facial colliculus here. You would like to go here so that you'll avoid damage to the facial nerve and to the sixth nerve. So with this anatomical knowledge, I choose to do the surgery in the semi-sitting position here in Farah Hospital. Our anesthetists are very much accustomed to the sitting position. We have done hundreds of cases. In fact, taking it in total, more than 1,000 cases of sitting position. I've never lost a case due to air embolism because we know how to deal with it. This is actually in the operating room of Farah, and we use all the neurosurgical observation for the cranial nerves, MEP and SEP. And this is the cell pictures of the operation. We are on the floor of the third ventricle. The midline is here. This should be here, the facial colliculus. This is the stria medullaris. Facial nerve is here. And there is a stain. If I go through the stain, I will damage the facial nerve. So I went to another stain here, away from the facial nerve. I went through that. This is the blood. And I discovered the DVA. I protected it with a batty and started to take the cavernoma out. I'm taking the cavernoma out now. So cavernoma is being taken from inside the bones. It's a large one, as you can see. And you have to remove it totally, because if you leave some, it will bleed again. So you inspect the cavity to make sure there is no remnant. Indeed, there is no remnant. You can see the white matter of the brainstem. And the DVA has been preserved. This is the stria medullaris here, and this is the midline. Let's see the video now. So what we have seen in the still picture, just to see in dynamic action. The DVA is here. I'm all the time aware of its presence, and I'm trying to protect it with this patty and try to remove the cavernoma out. It's not enough just to take the blood out. You have to take the cavernoma out. DVA is here. DVA. If you damage that, you will cause the brainstem major manifestation, maybe death. So you have to remove it in total. Total removal of the cavernoma, not only the hemorrhage. It's a very delicate surgery. Our anesthetists are on the alert to look for air embolism, to look for any changes in the cranial nerve monitoring. So we preserved, and the cavity is free. That's cure of the cavernoma with the preservation of the DVA. That's the cavity here. Okay. So this is the post-operative, the very following day. We don't wait for a week or month or year. The very following day, you can see the point of entry and the floor of the fourth ventricle, total resection of the cavernoma without any complications. And this is the patient himself. His weakness disappeared, the sixth nerve disappeared, remnant of facial weakness still there, but that recovered completely within 3 months. And this is the histology. We asked Dr. Abu Farsakh, our histopathologist, American board, to describe the pathological findings of the cavernoma.
My name is Dr. Hassan Abu Farsakh. This is the cavernoma is usually what we see is abnormal blood vessels. The blood vessels are very much coalesced with each other and attached to each other and close to each other, not the way that arteries and veins they form. Usually when you know the normal histology, artery, then go to arterioles, the capillaries, then venules, then vein. You see here that the large vessels together with no capillaries and no venules, and actually cannot really give them a name, whether these arteries or veins, because the wall is abnormal, and usually they are filled with blood, and the endothelial cell lining usually is disrupted. That's why we see many times hemorrhage, because the wall is abnormal and the lining is not normal, and you see hemorrhage with hemocysteine deposition, and you sometimes see brain tissue in between them. That's why they bleed very frequently because of the pressure of the blood. We do an immune stain to see the things. This is CD31. CD31 and CD34 and factor 8 are usually the stains that we use for endothelial cell markers. And you can see how the wall is very thin, and the blood vessels, some of them they don't even have a wall, and they are close to each other. And sometimes you can see disruption of the lining. The brown staining is the one, the staining that we is the one that indicates and this is EMA, the membrane antigen, is usually indicated to see if there is any meningeal tissue or any tumor in between. This is factor 8. The other stain that we use for endothelial cells, I mentioned 3, CD31, CD34, and factor 8. And you can see it stains the lining of the endothelial cells. You can see the lining of the endothelial cells. It's positive brown staining. And you can see the blood vessels are very abnormal in shape, dilated and ectatic, close to each other. This is typical of cavernoma. This is GFAP. The GFAP is a glial tissue staining and brain tissue staining. And you can see it is present in between the brain, the dilated blood vessels. Synaptophysin to see if there is any ganglion cells or cortex. It's negative here, so it's not in the cortical area. So this is usually the histopathology of cavernoma.
So we have seen the DVAs associated with cavernomas. It can be associated with aneurysm. A paper from China, 2018, ruptured aneurysm associated with DVA. What do you treat? You treat the aneurysm. Another paper from the States in the vascular occlusion of ruptured aneurysm associated with DVA. AV fistula, the same. like in this paper from Italy. They can be associated. They can also be associated with the subintravenous varix here, like this case. And they can be associated with Sturge-Weber syndrome. Paper from the States about the association between Sturge-Weber and the DVAs. And again, I asked Dr. Hazem Habboub, potential radiologist, to tell us about his case.
Thanks, Dr. Ibrahim. In fact, we have seen DVAs more with the AVMs than the most common is cavernoma, but we have seen them more associated with AVMs rather than aneurysms, maybe because of the same spectrum of disease. What we think as interventionalists is that the DVA is mainly a venous disease. The cavernoma is a capillary disease. So they are in the trans, and this is why we think that the formation of cavernoma, it follows the DVA thrombosis or something like that. So this is the theory of them. With AVMs, of course, it is also associated. Probably the same thing is that you have a DVA which is thrombosed, and then it initiated an increase in the venous pressure, and then you need a higher pressure. So there is a transformation. This is the typical. This is a lady. She presented with paresthesia in her left upper limb and lower limb with occasional headache. And what we can see is that there is a blush, but with no significant still early venous filling. We see mid-venous filling, what we call venous filling in the mid-arterial cycle. And there is a huge caput medosa suggestive of suggestive of DVA. In this case, to confirm this, we did selective because we were intending to treat this patient. And in fact, we treated this patient with embolization. And this is, you can see the microcatheter here. We went through the anterior cerebral artery and we injected into this malformation. And what it shows here that there is an early venous filling. So this is typical of capillary with DVA that has been treated. This is another case. This is we can see the diffuse flush of the capillaries here, filling also early in the arterial, in the mid-arterial phase, and you can see the dilated veins around them. In this case, we did not treat, but you can see on the late phase there are two large draining veins with DVA suggestions.
DVA solo alone, DVA associated with capillomas, aneurysm, telangiectasia, EVMs, etc. And we forget that they can also be associated with tumors. Paper here, cranopharyngoma associated with DVA. Can be associated with MS, multiple sclerosis, established multiple sclerosis patients, and they found the DVA. Can be associated with gliomas. Inside the glioblastoma, inside it, there was DVA. Again, diffuse gliomas associated with DVAs from France. 2019, diffuse pontine gliomas associated with DVA. What is the DVA? It could be intra-lesional, it could be extra-lesional. Another paper from China, 2021, new one, diffuse glioma with DVA inside. So the reporting of MRI should be more deep, should be deeper, should be intricate, should go subtle. The reporting in the Middle East is not up to the standard, I must say. And I heard the word, there is no aneurysm and no AVM in reports in the Middle East. Vascular lesions are not only aneurysm and AVMs. If you write no aneurysm, no AVMs, please write no telangiectasia, no cavernomas, no DVA, no nothing. But those two has been legacy of the past and still lingering. Stop using them. This patient showing you association of DVA with a tumor. A 74-year-old lady from Iraq. She had seizures and left-sided weakness. You can see the drift of her left arm, the lesion drift, and this is her tumor, very unusual tumor. But I was really worried about these structures here. I thought they are DVAs, and they are circular, they are serpentine, they are troublesome. Look at this. This is not a normal vein. This is not a normal anatomical vein that you know from the medical school or from your studies. This is a vein which is situated there wrongly, but it is draining normal brain. And the MRV showed the caput medosa. Clearly. You can see it here. So these are still pictures of the tumor. This is the midline, this is superior sagittal sinus is here. And this is the tumor in the frontal area. And this is the frontal lobe. So I started removing the tumor. At the end, when I remove the tumor completely, you can see the DVAs in the white matter. Lots of them, like sharks, waiting to bite you. But because I knew they were there, I could preserve them. And this is post-op. As you can see, DVA has been preserved and the tumor has been removed. And this is the tumor, again reported by Dr. Farsakh as aggressive angiomatous meningioma, lots of bleed. And this is the patient fully recovered, and she went on. With this, I finish, and I will take questions, and later on, we'll take questions from the auditorium. June, are you there? Are you there, John?
Okay, very good. Thank you, Dr. Sbeih. Any comments from the panel on what the Sbeih, Dr. Nahar? Do you want to say a word or two? Are you there, Dr. Nahar?
Yes, hello.
Oh, good. Welcome.
Good evening. How are you, Dr. Sbeih?
Hello, Jalal. How are you?
Oh, fine. Thank you. Thank you for just very exciting rare cases. And it's good chance to see Dr. Hazim again. I spent with him a few days in Amman many years ago. He's really a fantastic man in interventional in the Middle East. My question to you.
Jalal, can
Yes.
I just tell the people, because they are not hearing you, Dr. Jalal is from Syria. Are you in Syria now, Jalal, or where?
I'm actually working in the border of Turkey, Syria, since a few years after the noisy in Syria and the war in Syria.
Okay.
So I'm still there.
Between Syria and Turkey, and you have visited Dr. Hazim Haboob, and you know him very well. That's what you said.
Yes. We sent him some cases from Syria before the crisis in Syria. Anyway, these rare cases, I want to ask you about the situation in the system, like the trigeminal neuralgia. We have many cases. So what you suggest for studying these cases? You know, in trigeminal neuralgia, we will be surprised many times by the arteries, and very rare to find veins. But if you find dural venous anomaly or cavernoma, so this will be will make the operation so hard. So what you suggest, is it to 3 Tesla MRI studying before the surgery, or what you suggest for the trigeminal neuralgia?
So the question for our audience here is about the trigeminal neuralgia. What should you do as a study to study a patient with trigeminal neuralgia? As we know, trigeminal neuralgia could be primary, could be secondary to arterial loop or venous loop, or capillary loop, or cavernoma, or DVA. So the best you can do is a 3 Tesla, 10 cuts, high definition, followed by CT angiography or conventional angiography, and then study the normal courses versus the abnormal courses of the arteries there. I have to remind people that every nerve in our body has a complex of vessels. So we have the superior complex, the middle complex, and the inferior complex. For example, the inferior cranial nerves, the abnormal courses of the arteries there. I also remind people that every nerve in our the glossopharyngeal vagus and accessory having the pica with them, and the facial nerve, the vestibulocochlear, having the pica, the ICA there, and the trigeminal has the superior cerebellar artery. So there is a normal artery with each of those nerves, and most people do not have any neuralgia. So you have to have abnormal vision. You have to know the normal anatomy, so that when you study the angiography or the 3 Tesla or the SWI, you can tell what's the causation of this. I hope I have answered your question, Jalal.
Yes, thank you. Second point, as in definition is cavernoma, usually we find it in the interstitial tissue of the brain, but the venous anomaly mostly in the cisternal part of the brain. So how can we conjoin them in the pathologies in the intercistern? And it's mixed now with the cavernoma cases. So how can we understand this point, please?
Just look at the cavernoma. If you are dealing with a cavernoma or DVA, most, as you said, it is interstitial. It is not in the subarachnoid space. Arteries, veins are in the subarachnoid space, but DVA and the others are interstitial. So one can differentiate this from the other.
Thank you very much. Thank you.
Nice
Wait
to
to see you next 2 weeks in Istanbul.
In Istanbul, yes,
In Rotterdam. Yeah. Thank you. Take care.
John, any questions?
Okay, well, I want to show you one thing, Dr. Sbeih and Dr. Nahar. It's not correct. We have more people watching this broadcast, and I'm going to show you. Okay, this is my log, and you see this number 373. It's
This
not
is a number
nearly that many, but it's more like probably, I would say, 150 people watching who choose not to enter into the Zoom. They're just watching it on YouTube. So, Dr. Sbeih, there are more people benefiting from your lecture than what you think. It's more than the people in the panel. That'll change, because people in the panel right now, they're a little shy. They want to ask, and so they want to watch anonymously on YouTube, which is fine. But I think eventually we'll get people that aren't shy and come on the panel and that really understand the process, that it's for them to use. And it's just not for them to be as spectators, for them to be involved with the presentation. But that'll come. We'll build. We're determined. Right, Dr. Sbeih? We're determined.
Thank you very much. We'll see you in 2 weeks' time.
Okay, thanks, Dr. Sbeih. Any idea on the topic the next time?
It's a case presentation, a rare case presentation of histiocytosis X in the third ventricle. So we'll discuss histiocytosis, or
Okay, very good. Okay, we'll see you in 2 weeks. And thanks, Dr. Nahar, for coming. And thanks for the rest of the panelists for coming.
Thank you
We'll
very
see
much
you in a
indeed.
couple